Before we move on through, though, remember there's 3 categories that I want you to put your patient in whenever you are looking at your cardiac management, and you're deciding on what algorithm you want to use, what your treatment's going to be, and how you're going to treat the patient. So the very first thing is that we take a look at our rhythm. And what are we asking ourselves on the rhythm? Not yet. There's 3 things about the rhythm itself. We're looking at the electrical conduction and the myocardial tissue. We're looking at, is it moving too fast? Is it moving too slow? Or is it moving at all? Alright? Because if you can make that identification between is it moving too fast, moving too slow, or is it moving at all, then bam, that already lets you figure out which algorithm that you're going to follow, right? If it's moving too fast for cardiac output to occur, we're going to put it under the what? The tachycardia algorithm, right? If it's too slow, we're going to put it under what? And then if it's not moving, we're going into the VFib, VTAC, pulseless VFib, VTAC, or the PEA asystole algorithm, right? Alright, so if we've made that differentiation, automatically, if it's not moving at all, they're going to automatically be a unstable patient, right? But if it's, especially on your tachycardias, we need to identify, are they hemodynamically stable or unstable? So we're looking at what? Excuse me. That's going to be on the recording. We're looking at what? To identify if they're hemodynamically unstable. So we're looking at their overall presentation, but then we're looking at our objective signs, right? What are our objective signs? Our blood pressure, our SpO2, our respiratory rate, our pulse. We're looking at our mental status, all those things, but mainly our blood pressure is going to give us our best indication of hemodynamic stability. All right? So once we've made the differentiation between the stable or unstable, then we've got 3 categories of treatment that we're going to do for all patients. And we may not do every category for each patient, but what are they? Pharmacological, electrical therapy, and non-invasive. All right? So obviously our pharmacological is going to involve our drugs. Our electrical therapy is going to involve what? Pacing, cardioversion, and defibrillation. And then our non-invasive is going to include what? Huh? Alright, so monitoring, but I'm talking about treatment itself. Vagal maneuvers, and also your compressions, right? Your CPR, your manual stuff that you do. Alright? So, we're going to move on forward with this. If you got something to write down, you don't have to write the whole scenario down, but 40-year-old man arrives at the ER accompanied by his family. He is complaining of palpitations after working outside for several hours. The assessment is as follows. So first off, what if somebody tells you they're complaining of palpitations? What are they really complaining of? What is that? Yeah, I've heard it described as it feels like my heart's about to beat out of my chest, or sometimes if somebody is going real fast and they throw a PVC, they can feel that little skip, and they'll call that palpitations. Also could be called feels like my heart's fluttering, or feels like my heart's racing out of my chest, all that kind of stuff. So, neuro, he's alert and oriented. Respiratory rate is 22. No respiratory difficulties. And his lungs are clear. Clear to auscultation. His CVS, strong peripheral pulses and a blood pressure of 125/80. His skin is hydrated, pale, warm, and dry. And then here's a rhythm he presents with. Alright? So let's just assume that this is, well, it's a little more than a 6-second strip. But we're just going to count it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25. So about here is going to be your 6 seconds. So about 220. You think that's about right? So what are we calling this? Alright, so it's definitely tachycardia. Rate of 220. Yeah, so we're probably going to go with the SVT on this, right? So, first question you need to ask yourself. Too fast, too slow, or not moving? Too fast. Alright. So what did you call it? Now go ahead and, I gave you all the answer, but go ahead and answer. Alright, so SVT. Alright. So we decided too fast. Now, stable or unstable? Just giving off the presentation that you just had just a minute ago. Stable or unstable? Hemodynamically, stable or unstable? Alright, so he's going to be stable. Just because he's got a heart rate of 220 right now doesn't mean that at this point in time he is hemodynamically unstable. What makes him hemodynamically stable? What information did you have? Yeah, his blood pressure was 125/80, right? Mental status good. He's alert and oriented. Alright, so he's definitely going to be stable at this time. Now, can somebody sustain a heart rate of 220? No. Alright? So what's your first line treatment? So we identified too fast, we identified stable. Now we need to identify which one of those three categories do we need to start our treatment with. No cheating. Two more people. No, just to remind y'all, you got your three categories of how you're going to treat. Remember, we went through our first steps. We identified as too fast, so it's going to put us in the tachycardia algorithm. We've identified that he's stable, so that's going to help us make a decision as to which way to treat this guy. Stable, guys, stable. If he's stable, got a good blood pressure and alert and oriented, we're going to try the least amount of therapy that we can, right? So we're going to do vagal maneuvers first, all right? Now, well, we'll talk about that in a minute. What are our vagal maneuvers? The book talks about the carotid sinus massage, carotid artery sinus massage. We don't really do that, all right? What are some other vagal maneuvers that we're going to try? Yeah, get them to try to bear down. I think somebody had said something about blowing on your thumb or something like that. Yeah. I mean, if you want to be a jerk to him, sure. Sorry, ma'am, your heart's beating too fast. All right. So you've performed vagal maneuvers and there's no change in the patient's heart rate and rhythm. What is your next step? Adenosine 6 milligrams, rapid IV push. If no conversion, give 12. Adenosine 12. If no conversion, give another 12. Amiodarone 150, repeat as needed, or attempt more vagal maneuvers. Alright, so adenosine 6 milligrams. Why do we do a rapid push on adenosine? Very short half-life. So the best way that I recommend doing it, and for those of y'all that were in my static station the other day, it's kind of a repeat, but if you've got your IV tubing, you know, if you've got your line right here, you got your IV tubing, so we're going to put our adenosine at the port closest to the IV site. Then we're going to go ahead and find our next lure lock, and we're going to hook our fluids up to it. All right. So, and then I'm going to have them close by, and as soon as I get ready to push that adenosine, I'm pushing that fluid right behind it. All right. I'm going to have my top clamped off. I'm going to go psh, psh, and get it in real quick, all right?
You clamp it off by the roll wheel,
I would just clamp it off.
I mean, how you hold it and push and throw it at the same time?
Come on, man. It's just a little rubber tubing. Can't be that hard.
You just crinkle up the end.
Yeah. Yeah. I'll show you. You give 6 milligrams of adenosine with no effect. 12 milligrams of adenosine is then given. The patient develops severe chest pain, vital signs, heart rate 220, blood pressure not obtainable, and a weak pulse. The patient also has level of consciousness changes. You should do what? Now remember about your patients, especially on these dynamic stations, these dynamic scenarios, the patient is dynamic, which means what? He changes. He changes. All right, 2 more. Okay. What's the difference in synchronized cardioversion and defibrillation? Yep, defibrillation is not synchronized. It does not hit the R wave. All right, so let's come over here just a minute and let's look at it. Somebody want to do it? Somebody want to walk me through the steps?
Go ahead, DC. You're not dead, man.
All right, so
Sink.
no, the first thing you need to do is put it in what?
You got the sink button. I don't think it's good.
Get your leads.
Pacer.
Right here.
No, not paper.
No,
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 y'all
no.
are all wrong. Good leads. How are we going to deliver electrical therapy? There you go. Keep going. Keep it. No, let him do it. Can everybody see? All right. So there's your pad. Now, what's your next step?
Yeah, we got a sink.
All right.
What's that? Oh, you fix inside. Yeah.
All right. Y'all see that? See the arrow on the R wave now? Okay. So that's where it's supposed to hit. Now what do we do? All right. So we got a shot. What do we set our energy at? Between 50 and 100. All right.
Start at 50.
So we're going to start at 50. All right. For us, I'm going down. Okay. Now what do I do? So we're at 50 now. So what do I do? All right. Start. All right. Then what? I'm clear, you're clear, we're clear, and shot. Alright. I got to fix it where it'll change you go back, but that's your step 2. Alright. Think y'all can remember that?
He did.
All right, so what was the deciding factor between determining if the patient required continued pharmacological intervention or when we decided we need a shot? What was the deciding factor there? Huh? His hemodynamics changed, but the big thing to me on that would have been that number 1, we could not palpate a blood pressure anymore, and number 2, that his mental status was definitely changed. Okay?
So defibrillation was the answer.
Synchronized cardioversion. So, the steps to performing synchronized cardioversion, everything that we just went through, you will be expected to be able to do that now. I mean, and it's not that big of a deal. It's just changing your pads, changing your leads to pads, and now on the E-Series, like ETS has, they've got where you can just switch it automatically to defibrillation, all right? and then you would work everything out of defibrillation instead of changing your pads and all that. It'll automatically swap it for you, your pads there. All right. So we talked about the difference in synchronized cardioversion and defibrillation. So defibrillation, basically we're trying to depolarize everything at one time, right? And trying to get it all back to where the SA node will pick up, right? With synchronized cardioversion, we're hitting the R wave, all right? So we're hitting more on the upper parts of the ventricles, trying to slow that conduction down, all right? Alright, and again, synchronized is set to correspond to the R wave. Unsynchronized is just whatever you got. And a charge delivered during the relative refractory period may lead to ventricular fibrillation. All right, what is that called? Where if you start getting depolarization or stimulus on the T wave during the relative refractory period, what could that result in? That was this phenomenon that we talked about. R on T phenomenon. Basically what it is that the ventricles are trying to relax, but at the same time they're trying to be stimulated again, and then it just causes just a whole bunch of mess and a whole lot of mass confusion. Alright, so moving on. After synchronized cardioversion is unsuccessful, the patient continues to deteriorate. The patient is now unconscious and has no pulse. That's what you see on the monitor. Alright? So, this is a dynamic patient. Now, too fast, too slow, or not moving. We're going to look more at the cardiac tissue now. At least y'all know the answer now. Alright? So obviously, it's going to be too fast, but it's going to be not moving, right? This really wouldn't be PEA. This would be more of what? I'm going to call this more of a V-fib type deal here. And even if it was a VTAC or a V-fib on the monitor, if it doesn't have a pulse, we're still going to call that a VTAC or a V-fib. All right, so that's important to remember. Now, if it was no pulse and we saw just a junctional tachycardia or something like that, then we're just going to call that PEA. All right, but this is VTAC or V-fib. All right, so what's your next intervention? One more. Give one synchronized shot. Why are we saying that over CPR right now? Because we watched them. We already had the pads on, right? We already had the pads on because of the unsynchronized cardioversion. And remember your chain of survival. Yes, early CPR is very important, but early defibrillation is very important too. And your mainline treatment for a VFib, pulseless VTAC, is going to be what? Unsynchronized cardioversion or defibrillation, right? Does that make sense? For those of you that answered the other way, does that make sense? Your patient does not respond to the defibrillation at 120. He remains pulseless. What should you do now? Deliver a second shot, give 1 milligram FEIV, give 5 cycles of CPR, check the rhythm and the pulse. So we're going to go ahead and jump into our CPR now, okay? We've shocked. Next most important thing, start the CPR, alright? So, y'all don't have to get up if everybody can see, but somebody come up here and deliver a shock at 120 to this guy.
At what?
At 120. Set it at 120 and then we'll move. Alright, everybody see what he did? So first off, he's in what setting? Pads. Alright. So then, y'all see what he did to increase or decrease the energy? Alright. So we're going to go to 10 now. We're going to pretend like this is at 120. So what do we do now? Alright.
I'm clear, you clear, everybody's clear.
Alright.
You shot.
Then bam. And that's all there is to it.
Good job, man.
Alright. What do we do immediately after we shock?
Start compression.
Yep, go back to compressions. That might actually be a question. After completing 5 cycles of CPR, your rhythm check indicates a second shock. You shock a second time with 200 joules without change. You resume CPR. While completing the cycle of CPR, what else should be done? Give epi, 1 milligram IV push, repeat every 3 to 5 minutes. Vasopressin 40 units IV push, replace the first or second dose of epi. Give epi 0.5, or either A or B is correct. One more. Alright, so either A or B is correct. So C is not an answer at all because epinephrine 0.5 milligram IV is not a correct dose. Alright? So question A, or answer A is correct, and answer B because we can give vasopressin to replace what? The first or second dose of epinephrine, right? You've given the epinephrine or vasopressin and have completed 5 cycles of CPR, no rhythm change. You deliver a third defibrillation. What will be your biphasic defibrillator setting? So this is your third set. Two more. One more. 200 joules. So you may start, depending on your monitor's recommended settings, 120, 150, escalating up to 200. 200 on your biphasic machine is going to be your max dose. All right. At one time there was a push, and I think it had made it to the protocols where everything across the board was just 200. But I haven't seen that as accepted now as it was. And so for all intents and purposes, it's 120, 150, then 200, and 200 is going to be the highest. What's the max on a monophasic machine? Do y'all know that? What's that?
360.
360. Yeah, and remember, monophasic machines, they're going to give a lot more electricity. And so that's why they're not favored as much. Alright, so you've shocked at 200 again, no rhythm change. You restart CPR 5 cycles. You have shocked and you have given vasopressors. You have continued with effective CPR. What medication should be considered at this point? Amiodarone, low pressor, atropine, or dopamine? Remember, think about what algorithm you're in. What algorithm are you in right now? All right, your cardiac arrest, but there's two different cardiac arrests. Your pulseless VTAC, VFib algorithm. All right. So just think about if you can break them down and you can think about what drugs are in each algorithm, then you would know that 3 of the drugs that are listed here are not in the VFib VTAC working arrest algorithm. Amiodarone. All right. So at this point, we're in an arrhythmia, right? What is the number one treatment for VFib or VTAC, pulseless VFib or VTAC? Defibrillation, right? If it is refractory to defibrillation, all right, if it doesn't respond to defibrillation, then we need to throw on what type of medication? An antidysrhythmic. Of those 4 there, which one is your antidysrhythmic? Amiodarone. Low pressure is what? It's blood pressure, but it's more of a, did you say? Yes, it's a beta blocker. Low pressure is a beta blocker. It ain't on your algorithms, all right? There is a beta blocker on one of your algorithms, on your tachycardia algorithm, but it's not low pressure. Which you could use low pressure if that's all you had. Y'all won't have any of it. Atropine, what is that? Yeah, it acts on the SA node and speeds your heart rate up. We don't really need any more help speeding up anything, right? Then dopamine, what is it? Well, it does have the chronotropic properties, and it also has inotropic properties, all right? So it speeds the heart up, and it makes the heart contract harder, right? So right now, we need amiodarone. So, good thing that I was here to save y'all, because y'all just saved the patient's life. After administration of amiodarone 300 milligram bolus, the patient converted to a perfusing rhythm. You should now consider starting an amiodarone infusion. Why are we going to start an amiodarone infusion? Right. There's nothing that says that just because I gave that 300 milligram bolus of amiodarone that it's going to carry that all the way through, right? Something caused this patient to go into VFib or VTAC initially. So if it does convert with the amiodarone one, then we know that the heart responds to the amiodarone, and so we're going to start just a drip, all right? So it's really 1 milligram per minute, all right? 360 milligrams over 6 hours. So if it's 1 milligram a minute, how many milligrams per minute are we given? Or how many milligrams an hour are we given? 60, yeah. All right. Now, y'all should be able to figure that up from your pharmacology class and your drip rate and all that stuff. What is the correct dosing for amiodarone in the pulseless arrest algorithm? 50 milligrams IV once. If this is not effective, give 300. 200 once. 300 once, then consider additional 150, or give IV infusion of 300 per hour. $300 is your first dose of amiodarone in the pulseless arrest algorithm. All right. Amiodarone is a what? Antidysrhythmic. Y'all look so excited to be here. All right. So lidocaine can be used in place of amiodarone if it's the only thing available. What's your proper dosage of lidocaine? Went over this last week.
Oh, I got this.
One more. 1 to 1.5 milligrams per kilogram for your first dose. That's the primary dosage that I'm concerned about, is 1 to 1.5 milligrams per kilogram. And then all you do is just cut it in half for your second dose. Make sense? 1 to 1.5 milligrams per kilogram. Great job. You saved the patient. He has been stabilized and intubated, but does not respond to verbal commands. He is transported to the hospital's ICU. Since the patient is not responsive, what would be the most important intervention in the post-cardiac arrest phase? Monitor waveform capnography, obtain an ABG, induce therapeutic hypothermia, or monitor O2 sat. One more. All right.
Yeah.
It's C. All those are important. All those are important. All these are important, but monitoring isn't going to necessarily save the patient's life, right? This patient fit a lot of the criteria for the induced hypothermia. What's the criteria for the induced hypothermia? Talked about it last week. What type of cardiac arrest patient qualifies to be cooled down? Huh? Has to be a witnessed arrest, and it has to be a VFib, VTAC arrest with defibrillation. All right. Does everybody understand what the therapeutic hypothermia is? So basically, in a nutshell, what it is that we've got this person that we witnessed them go into cardiac arrest. All right. We were able to jump on them really quick, so hopefully we don't have a lot of brain tissue that suffered from hypoxia, right? Because we were able to start CPR really quick. This patient, it's going to take several days for them to overcome this if they can, right? We need to slow the activity in the brain down to a point to where it doesn't require so much oxygen. We're going to slow metabolism down. So the way that we do that is we start cooling them off. We drop their core temperature down to 91, 92 degrees. All right? And so the bulk of the therapeutic hypothermia is going to occur in the ER and in the hospital, in the ICU, where they actually put these pads on, where it goes around the core and then around the thighs here, and it continually runs cold water through these gel pads that brings their temperature down slowly. But in the field, the way that we're going to do it, well, how will we cool somebody down in the field? How will we start?
Underneath their armpits.
Yeah. So we're going to put ice packs. Yeah, we're going to treat them like they were a hypothermic patient. We're going to put ice packs under their armpits, their femoral arteries, maybe on the carotids, and around the legs and stuff. So we're going to try to start pulling them off. Ideally, you want to start giving chilled IV fluids as well. The summertime in Alabama, or even the wintertime in Alabama, except this year, your IV fluids aren't going to necessarily be chilled unless you keep them in a cooler or a refrigerator, right? Now, that's one thing you need to be careful of, especially as it starts getting warmer, is that you don't want to give fluids that's been sitting on the dash of the ambulance all day long in 150-degree weather, if we ever have 150-degree weather. All right? All right? Y'all need a quick bathroom break? Y'all good? You respond to the home of a 65-year-old female who is now unresponsive. Family states that she began complaining of chest pain and passed out. You are unable to palpate a pulse, and the patient does not have spontaneous respirations. This is your patient's rhythm. You got a question next. Name this rhythm. Well, no, you don't. What is it?
It's a PEA.
Yeah. Why is it a PEA?
It shows the rhythm, but you can't put a pulse.
If you were doing a rhythm quiz, or if you were just looking at this and you didn't have none of this stuff up here, you'd call it what? Probably a sinus rhythm, right? You call it some type of perfusing rhythm. But we know the fact is that she does not have a pulse, so it's going to be PEA no matter what, across the board. So remember your H's and T's causes a PEA. Hypovolemia, what is that? All right, low blood volume, but not just blood volume. Fluids, period. Be from dehydration, things like that. Hypoxia, so lack of oxygen. Hydrogen ion. Somebody's in some type of acidosis, right? Maybe a DKA, or maybe having some type of renal issues. Hyperkalemia. That could be affected with your acidosis as well. Low blood sugar, and then of course low core temperature. Then your T's, your toxins, that's going to include your drug overdoses, your poisonings, things like that. Cardiac tamponade, most often seen with what? Where are we going to see cardiac tamponade? Most often we're going to see with some penetrating chest trauma, things like that. Tension pneumothorax, again with trauma, your thrombosis, your pulmonary, your PEs, or your coronaries. Alright? And then trauma, traumatic shock, increased intracranial pressure and all that. So you guys cool on your H's and T's. So, how would you describe the rhythm on the monitor? I just told y'all it's pulseless electrical activity. What should your immediate intervention be for this patient at this time? Alright, so what is it? CPR. We don't shock. We don't shock PEA, right? What are our two shockable rhythms in arrest? VTAC and VFib. Y'all should know this at this level now. VTAC and VFib. Alright? What IV medication will be appropriate to use in this scenario? Think about it. There's only one medication up here listed that you would use in this scenario. It's going to be your epinephrine 1 to 1,000, or no, 1 to 10,000, sorry. 1 milligram, right? Your 1 to 10,000 is your cardiac concentrated dose. So, your patient is a 46-year-old female complaining of weakness and nausea. Her vital signs are respirations 24, pulse 48, blood pressure 82/56, and O2 sat 93%. Her rhythm. Alright? So, going back to her assessment. Alright, first thing. Doesn't really matter what rhythm we're in. Her pulse is 48. Too fast, too slow, not moving. Too slow. Alright? Weakness and nausea, blood pressure 82/56, breathing fast, O2 sat 93%, stable, unstable. Alright. No. After determining your patient is in a bradycardic rhythm, after determining your patient is in a bradycardic rhythm that will require intervention, the first step you should take is, now, we identified stable and unstable, but there's kind of a kink in that when it comes to bradycardia. Identify and treat your underlying cause. You guys are paramedics. You're wanting to go ahead and jump into all this stuff, and let's go ahead and shock the crap out of him and give him so much drugs that he's high for a week. I don't know. You want to identify and treat the underlying cause, because what if it was a drug overdose? What if it was a narcotic overdose that caused that? Yeah, she's an older lady, but old people hurt too, right? But they don't react to medication the same way younger people do. What if it was that? Well, what if it was hypoxia? What if she was having trouble breathing? What if she was choking? I mean, I know these are kind of some way out there suggestions. Yeah, you could do that, and it absolutely would not work, but you could try it. You're welcome to. You got to identify and treat your underlying cause. Y'all were stuck on this. What's the first line medication for bradycardia? Is dopamine, adenosine, atropine, or epi? Atropine. Adenosine is not in your bradycardic algorithm. Adenosine is not in your bradycardic algorithm. Alright? Know your drugs, because you will know, if you know what adenosine does, adenosine slows the conduction at the AV node of a heart. If we've got a heart that's got a very slow conduction in the first place, we don't want to give any kind of medication that's going to slow down the conduction even more, right? Epinephrine is on your bradycardic algorithm, but not in this dose. What is on your right? So it's an infusion. If atropine is ineffective in treatment of a bradycardic rhythm, which electrical therapy should you consider next? Transvenous pacing, transcutaneous pacing, synchronized cardioversion, or unsynchronized cardioversion? Hey, you guys know something. Y'all know me, that's pretty great. So, somebody besides Hunter or Hayden, come over here and walk me through pacing. Somebody besides Hunter or Hayden. Okay. Can everybody see? Alright. First thing we're going to do. Alright. Alright, so you see, everybody see right here where he's got it? He's got it set at 70, it defaulted to that. Alright, so now what?
Turn the milliamp so I get captured.
Okay. Alright, there you go. Alright, keep going. Alright. Y'all see it? You see where he's got captured? Everybody see where he's got captured?
Yep.
Alright, so where did you get captured at? 80? So drop down to 78. It's very, very sensitive. So you need to do your best to increase in increments of 2 and decrease in increments of 2. Alright? So I'd say you got captured there, wouldn't you? Alright, so what do I mean by captured? Right. So you've got for every time that the pacer stimulates the heart, you've got a recurring or a following QRS complex, right? Okay? So that's all there is to it, okay? It's just making some adjustments. Alright? What should be considered for a patient who is a candidate for TCP and awake? Yeah. Definitely want to consider some Valium or morphine or both. Alright? So, we're going to go through these again in just a minute and talk about them. Alright. Let's go take about a